I'm Dr. Dinesh. Welcome you on behalf of the Alembic Pharmaceutical to this ISGCon faculty launch. First of all, sir, thank you for giving your time for this brief discussion. I request you to introduce yourself to the audience.
Uh, Hi friends, I'm Dr. V.G. Mohan Prasad, Chairman of VGM Hospital, Coimbatore. I've completed 36 years of my gastroenterology practice, and I've been the past president of the Indian Society of Gastroenterology a decade back. So, and also Endoscopy Society of India. That's about a couple of decades back. So,
Thank you, sir, for your brief introduction. Basically, we just want to understand the basic management of GERD and role of PPIs, prokinetics, and antacid in the management of the GERD. So, how do you approach medically to these patients?
yeah, today I think much more than acid peptic disease is gastroesophageal reflux disease because of the change in lifestyle and food habits and all that, and also increasing obesity.
Right, sir.
So people are very clearly shown that obese people, the fat pad, in the visceral, area produces so much of inflammatory cytokines.
Right, sir.
So there's a visceral adiposity that releases inflammatory cytokines. So people have reflux and it becomes erosive esophagitis. These people have more EE when compared to non-erosive esophagitis, the nerd guys.
Right.
So, like, you know that GERD is not a disease of mere hyperacidity. It's a dysmotility disorder of the esophagus.
Correct.
Right from the disordered peristalsis of the esophagus to laxity of the lower esophageal sphincter, and there could be a defect in the gastric emptying times, and there may be a delayed, like also duodeno gastroesophageal reflux. All these are components of GERD. So, just a mere acid suppression with PPIs is probably not be all and end all.
Okay.
I was probably one of the pioneers in combining prokinetics with PPI, which I've been doing for almost 33 years as of now.
Great.
Exactly. From 1990 onwards, the first prokinetic came into India. I've started using prokinetics in combination with PPIs. And what is it? How does it help? First, the prokinetics improve the esophageal clearance of acid,
Right.
augment the LES pressures,
Correct.
improve the emptying of the stomach,
Right.
prevent the duodeno-gastroesophageal reflux. In all ways, the prokinetics are so helpful. And the other advantage that I see, I have an opportunity to reduce the dose of PPI. Today, in the long run, beyond 10 years, there could be increase in the side effects if you are continuing high dose PPIs
Right.
for beyond 10 years. So, combining prokinetics helps always to deprescribe PPIs, to reduce the dose of PPIs.
Right.
So this way, the prokinetics and PPI are a winning combo, and we have enough number of articles already published
Yes,
on this.
sir.
Head-to-head trials of
Yes, sir.
PPI alone versus PPI plus prokinetics. So in reputed journals.
Right.
So we have all the data on that. So that way, I think it's very good.
So among the PPIs and prokinetics, how do you choose, sir? If there are any kinetic parameters, do you consider, or patient profile do you consider while choosing the PPIs or while choosing the prokinetics?
Like you know well that the West started using double dose PPIs in reflux disease.
Right. Sir.
So even there is an empiric trial where you use for 8 weeks double dose PPIs, and if the patient responds, obviously is a case of GERD. There is no response, look for something else. So the timing of PPI, like a morning dose, half an hour before breakfast is ideal when all the proton pumps, the hydrogen potassium ATPases are awake.
Right. Activate.
So that is the time you have to give the drug. So if you give it at night, half an hour before food, the efficacy goes down of absorption of PPI, because PPI is is a prodrug. It's
Right.
a sulfenamide moiety of the proton pump inhibitor that has to be activated. It's a prodrug.
Right.
It requires awake, proton pumps. So ideal timing is probably the morning half an hour before breakfast. So this way, instead of giving two doses, one, sometimes the compliance is at a problem. Patient may forget the night dose or find it difficult to take it. So a single dose of a proton pump with a drug delayed drug release formulation, a DDR type of a formulation, especially with the matrix technology that has been soundly grounded over the past 3 decades.
Right.
I think this will become probably the way to go. And to me, all PPIs are the same.
Same.
I don't see any difference in the PPIs. Some are rapidly acting. For example, rabiprazole is rapidly acting,
Right.
and probably lansoprazole is a very good drug coming immediately close to it. And then what happens is, like some of the drugs which go through the CYP pathway, cytochrome P450, the CYP 2C1 or 2E1, if I
Right,
remember
sir, right,
right.
you're right. 2C1,
So,
2E1, right.
yeah. So there, some of the drugs can compete with other drugs which go through the same pathway, like for example, clopidogrel. So
Right.
people said that clopidogrel again is a pro-drug. It has to be activated by the cytochrome P450 pathway. And if there is a competing drug, and much of the clopidogrel may not get converted from the pro-drug to the active moiety. So that was a challenge which very many people were worried. But some of the studies and the real-world evidence does not show that even the competitive inhibition is a major problem in the availability of clopidogrel in the blood, active moiety in the blood, even if you combine it with a PPI. So that will be one small factor. But I feel any delayed drug release formulation with the matrix technology probably will be the way to go. And even a double dose of PPI can be combined as a single dosing schedule half an hour before breakfast, which probably will be ideal.
And so what about antacids? Do you also use antacid in these patients?
I do use antacids because all PPIs take about 7 days to reach a steady state level.
Right.
So by day 7 or day 30, the efficacy of all the PPIs is going to be equal.
Equal.
It's not going to be much different from each other. So there, the first 1 week, because I use antacids, and especially the raft-containing antacids are a great advantage.
Right.
Because what happens is, in the fed state, there is an acid pocket in the fundus, the cardia region.
Right.
So, and as the food goes down, the the acid pocket stays up. And then what happens every time there is a reflux that happens in GERD, it's the acid that comes up.
Right, sir.
So the alginic antacids can combine with this acid pocket, neutralize it.
Right.
So they form a raft.
Barrier.
And once there is a reflux, the raft comes up and not the acid pocket. So this way, patients have a good relief. And also, till the day 7 when the PPI reach a steady state level in the plasma, so till then, the antacids are a great help, because we should remember, the patient does not come to you for GERD, does not come to you for APD, comes to you for a heartburn or a acid eructation or a stomach burn. So antacids come in very handy to take care in the first 1 week. And then what I do is later on, I put them on demand antacid therapy whenever required on an SOS basis.
Thank you very much. Thank you. Thanks a lot.